with Gemelli Biotech, the makers of the Trio-Smart and ibs-smart at-home GI tests. We are absolutely thrilled to have you here tonight, and we hope that this webinar provides you with valuable insights on your gut health journey and hopes of helping you feel better quickly. It is my absolute honor to introduce Dr. Mark Pimentel. He is an internationally recognized leader in the field of gastroenterology and microbiome research. Dr. Pimentel is the executive director of the Medically Associated Science and Technology Program, or it's called MAST, at Cedars-Sinai, and one of the foremost experts in SIBO, IMO, ISO, and IBS. His groundbreaking research continues to revolutionize how we diagnose and treat these complex conditions, and he's paving the way for more effective solutions for patients everywhere. Dr. Pimentel tonight will begin with a presentation covering some of the key insights of these conditions. And afterward, he will answer some of the pre-submitted questions that came in when you registered for this webinar. And then we will transition into live chat questions as well through the chat box. So without further ado, Dr. Pimentel, the floor is yours.
Thank you so much. I had a hard time coming up with 10 slides. I have a little over 20 slides because there's so much new information. And then I always have trouble because when there's so many people coming online, I don't know how many people online are familiar with SIBO and how many people are newbies to this space. And so I want to at least cover some basics and then cover some of the new advances and try to at least, and I could do 200 slides because there's just so much going on right now. And I mean that really truthfully because it's crazy what's going on in SIBO right now. But let's start with what are the causes of SIBO? So remember, SIBO, it's a diagnosis. It's causing bloating. It's causing symptoms of pain, diarrhea, some cases constipation. We'll get to that. But something has to make the overgrowth occur. Why is it happening? So this is the sort of the list of things that make it happen. So mechanical causes. So if your bowel is blocked or it's not flowing correctly, it's going to fill up with material, fluid, debris from food, and those sorts of things. And so then you're going to get a buildup of bacteria. So there's a laundry list. But if you look at the bottom, irritable bowel syndrome is the number one reason. When I say the number one reason, so if you had 100 people with SIBO, the majority of people, it's irritable bowel syndrome. So I'm going to spend a lot of my time focused there. But I want you to understand that if your SIBO doesn't get better, if you get treated and it doesn't get better, you got to be looking for some of these other things, or at least the doctors that are treating you should be thinking about these things. And I've got the list here. I'm not going to go through them in detail, but I do have a slide that sort of walks through some of the things that I worry about because adhesions are quite common. So if you have an adhesion because you had previous surgery or you had a tubal ligation or an appendectomy because you had appendicitis, you can get adhesions. And they're like, it's sort of like a bent hose. You got a scar that's connecting two loops of bowel and creating this bend here, and then fluid can't go through it, and then bacteria builds up. That's one example. Endometriosis can do this. Crohn's can do it because Crohn's can cause the thickening of the bowel, and then things don't flow correctly because the bowel can't move freely, the muscles can't contract freely, and so you can get it there. There's all sorts of weird things. I'm not going to get into. A cecal bascule is quite rare. Tumors, of course, are also on the list because if something's blocking the bowel, that can cause overgrowth. So we shouldn't close our mind. So if somebody's not responding to the treatment for overgrowth brilliantly, think about why their overgrowth is there and see if you can treat the underlying cause as another way of evaluating why the SIBO is there. But I really want to turn my attention to the biggest group, irritable bowel syndrome. And this is the fact that we think IBS is caused by SIBO in a bulk of it, in the majority of it, that had created some controversy because IBS was always thought of as a psychological condition. But we now know that's not the case. And we are looking at root causes of IBS. And we think about 60% of IBS is SIBO, ISO, or IMO. And we're going to get into those three categories of overgrowth of bacteria as we get through this lecture. And then I'm going to try and take you to some treatment options. But there's this theory that is evolving. The brain and the gut are connected. Absolutely, the brain and the gut are connected. And because of the vagus nerve, because of various communications with the bacteria producing chemicals like serotonin and other chemicals. So yes, there is a connection. But when your gut is not working, and your brain check engine light comes on. Okay, so, but you don't break the light on your dashboard because it's on. You go to the engine to fix the engine problem and the light turns off. And I think that's a good analogy of this gut-brain connection, is that what's broken, in my view, in most patients with IBS is the gut, and the brain is getting these check engine lights. And sometimes that not only the check engine light, but the fact that you're running to the bathroom over and over again has got to be anxiety provoking, etc. So we know that that connection is there. So I don't want to dismiss that, but I just want to address that because you get a lot of noise on the internet, on social media about all these different aspects of IBS. And I want to make sure we cover a little bit of everything. But what we know for a fact, and this is undisputed now, that food poisoning triggers the development of IBS. So you were fine until you went to Cabo, or you were fine until you went to ate at a particular restaurant and you got food poisoning, or you were fine until, and so food poisoning is a absolute cause of IBS. It's like 1 in 7 people who get food poisoning will develop IBS from food poisoning. That's amazing. And we know this to be a fact. So we now know a cause of IBS. But the question is that connected to SIBO? And this took over a decade of work in our lab and by others around the country, that food poisoning has a toxin in it. And that toxin, called cytolethal descending toxin, in Salmonella, Shigella, Campylobacter, E. coli, the 4 horsemen, you could call them, of food poisoning that trigger IBS. And that toxin in and of itself can lead to irritable bowel syndrome. And how it does this is that the toxin has a similar sequence to it. It forms antibodies to the toxin. Part of this has a similar sequence to vinculin. And vinculin is a very important protein for the nerves of your gut so they can interconnect. And it's sort of like the wiring in your house, and half the wires are pulled out, so only half the lights turn on in your small intestine. So your small intestine is not moving correctly because half the lights are on or half the wires are there. And when you have these antibodies to vinculin. So if you want to say what is causing SIBO, what is the root cause of IBS, this could be the root cause. So if we can get rid of this antibody, everything wakes up. The nerves reconnect, the wires reform, and we're back to normal. And that's what we're really focusing on in our research for the future. We don't have such a drug yet, but stay tuned to the end of the presentation because we're close. So this antibody, though, can be measured as part of the ibs-smart test, which Jameli has, and you'll hear a little bit about that from Paige. It tells you food poisoning caused it, and you have these destructive antibodies. But if we give this toxin to rats, they get antibodies to this toxin, CDTB. And because of that, the fluid, the water weight of their stool goes up. And the higher the antibodies, the worse their diarrhea is, if you look at this third graph on the right. But what happens when the wires are pulled out? Like I told you earlier, the gut slows down and bacteria build up. And this is the connection to SIBO. And even in animals, the bacteria building up go in one of 3 directions. One direction is not much happens. The green balls here. Or they go in one of 2 bad directions. Too much E. coli, which is hydrogen production, or too much hydrogen sulfide, which is other bacteria, specifically desulfovibrio in rats. So we know that if you develop IBS from food poisoning, you're going to get one of these 2 bad microbiomes in your small intestine, or one of 2 types of SIBO or overgrowth. So now going to IBS, breath testing in IBS, it's a knock out of the park here. This is a 25 study meta-analysis saying if you do a breath test in IBS, the chance of it being positive is much higher than healthy people. Full stop, full conclusion. You don't need more studies. We have 25, 15 of them are considered high quality studies. And so we know that IBS and SIBO go together by breath test. Now, one of the things that you're going to be in a tug of war with if you read social media, if you read anything about breath testing is, can I do glucose or should I do lactulose? Glucose, you don't need a prescription for glucose. Lactulose, for some strange reason, is a sugar, but still requires a prescription, and it's just 10 grams of lactulose, but it still requires a prescription. But what happens with glucose is it gets absorbed so quickly that you run out of steam. So you'll see the breath test, it goes up and then it starts to go down because it's being absorbed by you. You're absorbing all that glucose. And I'm 6'4". I'm going to absorb more in my mouth, in my esophagus, in my throat, in my stomach before it even reaches the small intestine than somebody who's smaller frame or smaller body or smaller GI tract. And so glucose is not the greatest substrate. And what we learned this year is that glucose misses people who are sick, because the people who are negative on glucose breath test are sicker than the people who are negative on lactulose. So the glucose is missing people who could benefit. So this is proof of what I've been saying for years, that lactulose is better. It's going to pick up more people who have a problem with the overgrowth. But now we have 3-gas breath testing. For years, it's been 2-gas breath tests, and the new development with the Trio-Smart is 3 gases, because we now know there's hydrogen sulfide producing. I showed you that in the animals, and in humans is the same thing, and hydrogen producers. The third gas is methane, which is associated with constipation. So you really have to measure all 3 gases to get an understanding of the microbiome in you. The sensors in the new Trio-Smart are more accurate than the typical sensors in other instruments because it can measure it within a fifth of a part per million. So you never get confusion about what the results are. The bags are able to hold the 3 gases for 10 days for shipping. The bag system is designed to keep those gases stable in that bag for that period of time, and it doesn't alter the hydrogen sulfide. So it's important to measure all 3 gases. And we now know, I mean, prior to this year, people said, well, how do you know it's in the small bowel? How do you know that when you measure a breath test with the 3 gases, that you're measuring the bugs that are in the small bowel? And this is now accepted for publication. And basically, it shows that if you use the 3-gas breath test, the Trio-Smart breath test, if you have methane bugs are in the small intestine. If you have, and these are the bugs, and the most important one is this Methanobrevibacter smithii. If you measure hydrogen sulfide on a human's breath, you have hydrogen sulfide producers correlating with that breath sample when you look at the small intestinal microbiome. So proves that the breath test is actually telling us exactly quantitatively how much of these bugs are there that are out of proportion, out of the normal range. What's super interesting, and this goes with what we've always known about irritable bowel syndrome, and particularly hydrogen sulfide. We now know so much about hydrogen sulfide in a short period of time. But basically, whether you look at hydrogen sulfide in humans or you put these bugs from humans into animals, you get the same changes in the gut. And the changes are your motility's changed, you feel pain more, you get fluid shifts, meaning you get diarrhea, and immune responses and other things. So now that we know there are 3 gases, we have to treat this. So one of the things that we've known for a long time is that rifaximin is quite good for hydrogen. And this is hydrogen breath testing. This is treatment of SIBO with rifaximin. This is a meta-analysis of 32 published studies showing rifaximin helps SIBO. Now, one of the questions that always comes up is, does it help all SIBO? And there's always a percent that get better and a percent that don't. But overall, rifaximin is beneficial for SIBO in general. I throw this study up there because I like prevention. I want to prevent IBS, but it's also a really important slide. It's an animal study, but it's a really important slide to prevent the antibodies from going up further. So this is an animal study we did. This is 2011. But if we gave food poisoning to animals and we gave them rifaximin the day before they got the food poisoning, the day of the food poisoning, and the day after, they had a much lower chance of developing IBS. And why is this important? Because you can prevent IBS if you're going somewhere where food poisoning is a very high rate. So treating food poisoning is really important. Don't let it ride. And secondly, if you have IBS already and you have these antibodies, you got to prevent. And rifaximin also prevents, and we do that with our patients, and I can get into that in the Q&A. For methane, it's different. This is a double-blind study we did in 2014. You got to give neomycin plus rifaximin. This is what we recommend to our patients with methane. Methane constipates. Methane slows your gut down. The methanogens are different. They don't come from food poisoning. They come from reasons we don't understand why they're now blooming or growing in high number in the colon and in the small bowel of patients with this constipation side of things. But neomycin and rifaximin is what we use, and sometimes we substitute neomycin for metronidazole. We published a paper on a new elemental diet. This is palatable. It tastes good, so it's tolerable. It can be done for 2 weeks. And we did 30 subjects in this clinical trial. Everybody finished the trial. Everybody was able to take the diet. So it was tasty enough for people to finish it. 73% normalized their breath test, and 83% had symptom relief based on their symptom questionnaires. And also, that bug that produces methane in those that had methane was decreased when methane was decreased. So we're really, and fusobacterium went down, which is a hydrogen sulfide producer. So the elemental diet is a good option, A, if you can pay for it, and B, if you can put up with liquid diet for 2 weeks, but at least it tastes good now. I'm going to talk to you about 3 exciting things because I like to give you the future, because this is the future. We now in our hands in the lab, we have a drug that can reduce methane by 70 to 90%. And so by blocking methane production, and this is the animal study, these animals had the methanogen, that methane bug, M. smithii. They had constipation. We gave them the drug. Their constipation diminished. Their methane went down. This is for the future. This is the future of treatment of IMO, or intestinal methanogen overgrowth. The treatment future for IBS-D, or patients with SIBO and ISO, the hydrogen sulfide, we now believe is based on this work. Half of the bugs, meaning the bugs that produce hydrogen and the bugs that produce hydrogen sulfide, are living in the mucus, and the other half live above the mucus, sort of floating. The bugs above the mucus, rifaximin can hit them. The bugs in the mucus, rifaximin doesn't dissolve in liquid, so it doesn't get to them. So we decided to mix rifaximin in a particular way and deliver it to the small bowel with N-acetylcysteine, which dissolves mucus, and we get much better improvement. This is your regular rifaximin in a study we finished and presented at the big meeting in San Diego this spring. And this is what happens if you add the NAC and rifaximin together. So many more things are better. So many things are more statistically significant. We're starting a 3-center phase 3 national FDA-approved study to get this along so that patients can get this new, better, improved treatment for IBS-D and SIBO and ISO. Finally, we published this paper this summer, and it's just out. And if you can get the anti-vinculin antibodies down, those patients, the IBS starts to disappear and the SIBO starts to disappear. And we now have sequenced all these antibodies, and we're in the process of developing a treatment to get these antibodies out of the bloodstream. Stay tuned for that. In about a year, I'll have some big information on this, because we should have something in hand in a year to start trials or safety preparations for the FDA. So super excited about this because this could be the cure, quote unquote. I know that's ambitious. I don't want to overpromise, but we're working on it. That's all I'm saying. We're really trying to get to the bottom of this. But in the meantime, we have these three groups, and the only way you know these three groups is you measure the three gases. So we have the traditional SIBO in the middle. We know the bugs there, E. coli and Klebsiella. We got the condition on the right, the constipation condition. We know the bugs that are producing the methane. And now more severe diarrhea is ESO, or hydrogen sulfide production. And to be honest, we have patients who have combined. So we have some with ESO and SIBO, ESO and EMO. And so you have to tailor your treatments accordingly. So the root, we're getting to the root of IBS in that 60% of IBS patients. The root is there's SIBO, and we use either rifaximin or elemental diet for that at the moment. If you're EMO or methane, we use rifaximin plus neomycin or rifaximin plus metronidazole. For ESO, we use rifaximin plus bismuth. That works for now until we get these new drugs through the FDA process. The two new therapies I talked about today are coming. Super excited about that. Measuring anti-Vinculin and anti-CDTB antibodies through the IBs-smart test, I do this routinely because if the anti-Vinculin antibody predicts that you have IBS and we know what caused it, it's also important to tell us how easy you are to treat and take precautions when you travel. And we're developing a new therapy, we hope. So keep your fingers crossed for us on that, because that may solve the whole problem in the long run. So in conclusion, SIBO is common. It's important to know the cause of SIBO. You can't just, if you're not responding, make sure you don't miss something other than just IBS. Food poisoning causes the bulk of this, and we talked about the two antibodies that are up. This is not your grandpa's SIBO. This is not the old SIBO that used to be in the textbooks. This is the new generation of SIBO with these three categories that we talked about, and hydrogen sulfide as that new kid on the block, which is giving us a better understanding of some of the more challenging patients that we've had, and new therapies are coming. So I'm going to stop there and move on to the next section. So Paige, I think you wanted me to do the pre-submitted questions first, right?
Yes, perfect. That would be awesome. We're going to spend some time with 10 or 20 questions that were pre-submitted from the registration link that we all have.
Okay, perfect. Well, I'm super excited to get to these because they're really, really good questions. And clearly a lot of you have some experience with this or are having trouble being managed with this as well. I can't give you medical advice, but I can tell you what I do from my perspective for some of these problems, and that's the way I will answer it. And I will do this for about 10 minutes, and then I will go on to the live questions, because there's more questions here than I can answer and probably more questions live, but I want to make sure the live folks have a chance as well. So Melissa, I hope you're on, but Melissa asks, after SIBO or EMO has been eradicated by antibiotics, what can you do to restore a healthy microbiome? So what's interesting is that there's a lot of people trying to develop things or sell things online, pills that will reconstitute your microbiome and all of that. So what I want you to do is I want you to think of it this way. You've got E. coli and Klebsiella and these hydrogen sulfide producers there. And when they're there, they're producing chemicals. They're out-competing everything else, and they're destroying your microbiome. It's sort of like weeds in your garden, right? So the weeds take over, the vegetables don't grow, nothing is produced. As soon as you take the weeds out, the garden grows. And so the rifaximin treatment, we've seen this in our microbiome data. As soon as we give the rifaximin and we check the microbiome after, all the bugs are coming back. And there was a massive study that was done out of Cork, Ireland. We weren't on that paper, but it's a very important paper, and it showed that the way rifaximin works in IBS is that it makes the microbiome alive again and shift back towards normal by getting rid of the bad actors. So we see it in our data, and the massive study that combined all existing data on IBS showed that in this recent paper that was just published less than a year ago. So you shouldn't have to do anything. And the problem is we're not fixing the wiring, right? Remember I told you at the beginning, the wiring is a little broken. So you don't want to put fish food in there. You don't want to put fiber. You don't want to put and we'll get to diet here and some of the other questions, because you're feeding the bad guys. The bad guys are 60 times more capable of fermenting than the good guys. And so like E. coli and Klebsiella is 60 times more efficient at fermenting. They're going to win. So if you put food in there for them, you want the food for you, not for them, because because of the wiring and the slow transit, they're going to come back and overgrowth comes back. Jim asks, just finished a 2-week course of rifaximin and neomycin for intestinal methanogen overgrowth. That's one of the things that we do in our clinic. And have heard archaea repopulate quickly if not eradicated. Archaea are actually quite slow to repopulate because they're slow-growing organisms. So it's not quite like that. But how long would you recommend waiting before doing another breath test? So usually I wait a week after the completion of treatment to do another breath test in my clinic. But and when would you consider a second course? So if you're incompletely treated, so this is going to answer a few of the questions that I've perused here, is that, you know, if you're 90% better after rifaximin or rifaximin and neomycin, you don't need another breath test. Don't waste money, don't waste time, because the breath test isn't going to make you that extra 10%. But if you're 40% or 50%, you might have incompletely eradicated. And if that's the case, you need to do another breath test. There is an occasion where you want to do another breath test. Let's say you've treated and you don't feel better, and you do another breath test and the overgrowth is still there and you don't feel better, or the overgrowth is gone and you don't feel better. Then you need to look for some of the other causes of symptoms. So for example, if you had an adhesion, you'd be bloated and distended from the adhesion, plus you'd have overgrowth on top of that. And if you treat the overgrowth, you still got the adhesion, you still got the distension. So you got to look for the adhesion. So the breath test, by finding that it's normal, but you're still symptomatic, tells you better look for something else. The breath test saying, hey, the overgrowth is still there. Why is it so difficult to treat? You need to look for why the overgrowth is still there. And could something be more sinister going on? So I think that answers a few questions. If you test, Adam asked this question. If you test positive for the antigens on the take-home blood test, indicating that you had food poisoning, what do you do next? So one of the things that, reasons that maybe people don't do the blood test as often is because, well, I'm not going to do the blood test because, so what? I can't treat it yet. There's no drug for it yet. But that's not my approach in clinic, because if I know that those antibodies are positive, I make for darn sure that the patient travels correctly, that I counsel them about traveling, careful eating. And I don't mean careful eating what you eat. I mean careful eating, maybe you shouldn't eat at the roadside stand where they're cooking food in the open, like, or a food truck. You need to think about your food choices so you don't get food poisoning again, because IBS patients have 3 times higher chance of getting food poisoning. And what we think is that those broken wires, because of these antibodies, means that you're the person that can easily get food poisoned again. That's why they damaged you. That's why the Campylobacter, the Salmonella damaged you. So they keep using you. But then your antibodies go higher. Then you're sicker and sicker and sicker, and you're harder to treat for your SIBO. So knowing you have these antibodies, I change exactly how people behave, where they go, how they go. And then in some cases, if the antibody is really high, if you're traveling to places, certain places in the world, I'm giving rifaximin prevention a little bit with every meal, so food poisoning does not come. Leslie asks, so if you have the ibs-smart, those antibodies, should you retest and how often? If you take rifaximin for your SIBO and you had the antibodies and your SIBO goes away, you feel great, the antibodies aren't going to change. So you don't need to measure the antibodies after a treatment with antibiotics like you would the breath test. You want to measure that at a longer interval, because it takes about a year 2 years to see the change in antibody, because this is like you getting a vaccine, right? The antibodies are going to stay up because you have vinculin. Your body has vinculin, so it's going to keep forming those antibodies and only slowly come down. But if they are coming down, that's a good sign. And I've had patients where the antibodies go back to normal and their IBS goes back to normal, which is fantastic. So once a year is what I sort of rule of thumb. Lizzie asks, when do you test after finishing rifaximin? Oh, I'm sorry. When do you test and what diet do you use? So I kind of mentioned this 7 to 10 days after completion of the antibiotics. That's when I would do the second test to be sure it's gone. The diet, I use the low fermentation diet. I don't use low FODMAP. And the reason I don't use low FODMAP is because it's too restrictive. It actually reduces the microbiome diversity. So I use low fermentation, which is more liberal. And Paige can provide that for you if you like, if you just put a message in the chat, the diet. Mary Jo asks, after doing the elemental diet and biota, when should we retest for SIBO? If you're doing elemental diet, I always test again because that's a lot of work. It's expensive because you have to pay for the elemental diet. And so I want to know that it's gone before you know, right after you've done the elemental diet. So I'm more likely to retest after with elemental. Are there any new remedies for IBS-M? So IBS-M is really D. So when we did the original rifaximin study, it was D and M together. So it was non-constipation IBS. So it's really the same. And M has, so the way I see M is it's riding the fence between D and C. And so when you do a breath test, some of the M's are methane, some of the M's are hydrogen and SIBO. And so it's just on the spectrum of the gray parts of the spectrum. Are there any new treatment protocols or research on methane dominant SIBO? So I told you about CS06. So in about a year, we're going to start clinical trials in that. Fingers crossed if there's all the safety lines up perfectly. And we're super excited about that. So stay tuned for that because I think that's going to replace what we're doing now. What can I do after eradication to prevent relapse? So there's two things I do to prevent the overgrowth from coming back. And so let me describe this to you. First of all, low fermentation diet. And as I mentioned, Paige can send that to you. But the second is, if this is your first time treating overgrowth, I would just do low fermentation diet and see how long it is to relapse. If it's 2 years, you don't need to do anything more. And so why waste money? Why get another prescription? Why take a drug? My goal is to give people safe options and to minimize misery. I want people to be able to go to a restaurant, enjoy food, be as back to normal as possible. The low fermentation diet's like that. It's less restrictive. You could find any restaurant in this country with a food item from the low fermentation diet that we created, because the whole point was you don't want to be at a table with a bunch of friends and you're the one asking 20 questions. It's not convenient for you. It's not fair to you. It's anxiety provoking to you. Why would you want that? So it gives you the option to be able to easily pick something from the menu without being that person, you know, and I think you know what I mean. But if your SIBO relapses and relapses and relapses, or you have these high vinculin antibodies, we sometimes need to give a prokinetic at nighttime to make the wiring work. So remember when I said there was less wiring? So you can't bring the wiring back unless you get rid of the antibodies, which we haven't figured out yet. But you can turn the energy up on the wires that are there. So it's sort of like you have half the lights in the house. So the only way to see is to make the light bulbs that do work turn brighter. And so that's why we use a prokinetic. At least that's sort of a simple way to describe the prokinetic effect. All right, I'm going to do 2 more questions here, then we're going to open up to the main group. What can I do to prevent relapse? I have hydrogen SIBO and I took 3 rounds of rifaximin with no success. What are my options? This is from Patricia. So Patricia, again, I can't give you medical advice, but if I have a patient where they're not responding you got to do more workup. You got to the doctor has to take some effort and see why this is happening, why it's not getting better, and or it's hydrogen sulfide and you didn't treat the hydrogen sulfide. So I don't know if you did a 3-gas breath test or a 2-gas breath test. So that's another thing to think about. And then one last question. If a person has fructose intolerance, could that be the root cause of recurring SIBO rather than food poisoning symptoms? This is Heather. So fructose intolerance is that you have the inability or a lower ability to absorb fructose, and then it gets to the colon. And so as a result of that, you get this gas production and bloating. So you can't diagnose fructose intolerance unless you do a breath test for SIBO, because all SIBO patients will test abnormal for fructose. It's just a thing, almost all. So I wouldn't do, you have to do the SIBO breath test first and make sure before you check for fructose. Okay, so now I'm going to go to the chat and look for what questions are here. Let's see.
Okay, Jill has asked what kind of treatment you would recommend for a new diagnosis of IMO. They used the TrioSmart test to reveal that they had high methane.
Yeah. So in my clinic, again, can't give you medical advice, but in my clinic, and based on the randomized control trial I showed here in the slides, intestinal methanogen overgrowth, the first treatment would be rifaximin plus neomycin. Now, I'll give you just some pointers on neomycin. Some people are reluctant to take it because it can cause ear toxicity. So if you have hearing loss to begin with, when they say ear toxicity, they're talking about gentamicin, which is a drug they give by intravenous. Neomycin is the same class of drugs, but given orally, it doesn't get into your bloodstream. But it still has that label because the FDA says, okay, same category of drug, got to get the same side effect label. So I've never seen ear toxicity with neomycin, but if you do have any hearing loss, don't use that. Use metronidazole instead is what I do in my clinic. So.
Awesome, thank you. Okay. We have Donna asking, how long can I actually be on Motegrity?
So Motegrity's been approved in Europe before it was here, and probably been about 10 years on the market. People have been on it for 10 years straight, taking high dose Motegrity in and around the world. It still appears to be very safe. I'm not saying you should be on it for 10 years. What I'm saying is that what we do in our clinic is we use it at night after the overgrowth has been treated, if you're getting relapses, and we use only 0.5 milligram, which is half the dose of the lowest dose of Motegrity. So you could be on it for a long time, considering a lot of people have been on or 2 or 4 milligrams for almost a decade. So it's just a small dose, enough to kind of just get those light bulbs brighter, so that it prevents the overgrowth from coming back.
Thank you. Okay, we have Trisha who's asking, what do you personally think of Fodzyme? I cannot get my teenage son with post-infectious IBS and SIBO to follow a special diet, and this seems promising.
Yeah, so Fodzyme, it's an enzyme to break down FODMAPs. That's the purpose of it. The challenge, if you remember Lactaid, the Lactaid pills, if you were to drink a cup of milk and pop 2 Lactaids, you're going to digest 50% of that milk lactose, maybe, if you're lucky. The other 50% not. So it's going to take the edge off, but it's not 100%, right? Because you'd have to mix the Fodzyme with the food, put it in a blender, leave it overnight on the counter at room temperature or 37 degrees so that the enzymes can work, because the enzymes work at 30 body temperature. And then you risk getting food poisoning from the thing you left on the counter overnight because it's food. If you just push them together in a meal, you're not going to get full coverage, as we know with these enzymes, but it'll help a little. So it's possible that it has some benefit.
Thank you. Great. So Elliot is asking, I have a post-infectious IBS diagnosis. What would be next? I cannot take rifaximin.
So if you have post-infectious IBS and you have SIBO, one of the SIBO types, it depends which SIBO type. So you can do elemental diet. That's not an antibiotic. If you can't do antibiotics, that's what I would do in a patient who is intolerant. To this date, and I've been doing rifaximin for 20 years, almost, I can't recall on one hand at allergies to rifaximin. So rifaximin is one of the safest drugs we've seen, doesn't change the microbiome in a bad way. In fact, it makes it more normal, doesn't cause bacterial resistance, doesn't accumulate yeast in the stool, so women would not get vaginal yeast infections from rifaximin. So it really is one of the safest drugs out there. In fact, we did a what's called a harm study. And if you took all the studies of rifaximin and the matching placebo in those trials, the placebo was more harmful than rifaximin. Crazy. I mean, you don't see that very often with drugs.
Yeah. Okay, I think this is actually a good moment. I'm going to transition over to some of the Gemelli biotech products that do answer some of the questions that you're asking now. Dr. Pimentel, are you able to stay a few minutes afterwards and answer a few more of these questions that are coming in?
Yeah, let's continue with some questions after you're done. I'm happy to do that. So stick around.
Thank you. Thank you. We are from Gemelli Biotech. Again, we are the makers of TrioSmart and ibs-smart. So the TrioSmart test and the ibs-smart test are both at-home mail-in tests. The TrioSmart is a breath test that is the only test available that can measure the 3 gases that can help identify SIBO, IMO, and ESO. ibs-smart is also an at-home test, but it is a blood capillary test, so it attaches right to your arm, and that is going to detect the 2 antibodies to identify post-infectious IBS or IBS that is caused from food poisoning. TrioSmart, again, is the only breath test to measure these 3 gases. The results when you order online do directly get emailed to you. So they look like that on your phone with the different levels over the time frame of the test. And then also you have qualitative and quantitative results that will tell you if it's abnormal, elevated, or not elevated. The TrioSmart test is a very highly sensitive test. It's 20 times more sensitive than other instruments that normally only test for 2 gases, and we do test for 3. We are a CLIA certified test, and the best part is that there is no doctor's appointment needed to get this test. We do have an online system where you can enter your information, answer a few questions, and then we submit that to a doctor that we work with, and they review your submission, and then they approve and prescribe the test if need be, and the test gets delivered straight to your door. Also, we have always used glucose and lactulose, but lactulose was not available online through the online system, but now it is. So you have the option of ordering your TrioSmart 3-gas breath test with either substrate of glucose or lactulose. And the TrioSmart breath test is validated for both of those substrates. So you would want to work with your doctor to determine which substrate was right for you. The ibs-smart test, if you wanted to look at this picture here, that is the capillary Tasso Plus device, and that is where you attach it sticks to your arm, and it is virtually painless. You get a little bit of blood to fill up the vial, you pack it up, and you send it into our lab, and we can determine within 7 days, you'll get an email of if you have abnormal or elevated antibodies in your blood to determine if post-infectious IBS is your diagnosis and how to move forward. Post-infectious, again, IBS is the IBS that's caused from food poisoning. It is about 1 in 9 people who've had food poisoning in the past or can remember having food poisoning in the past will develop this post-infectious IBS as a result of a previous food poisoning. We have a code going right now because of this webinar that you're joining us with tonight for $50 off, and we have free shipping on all of our Gemelli tests. The $50 is for all of our Gemelli tests, which are available on getgutanswers.com. We have IBs-smart, we have TrioSmart, we also have malabsorption tests as well, which you can look into on that website as well. But GetGut50 is for a limited time, you can get $50 off when you do order online. We also have a giveaway. This is for Dr. Pimentel and Dr. Rezai's book, The Microbiome Connection. A lot of what he was discussing about LFE, the low fermentation diet, and how to eat and manage and live with what you have to deal with for now and manage it accordingly. And there's some really good tips in there, really good information. So if you wanted to enter with a QR code or that bit.ly code that's on there, you just enter your name and information, and we'll pull 2 winners to receive a copy of this book. Again, I just wanted to post this GetGut50 code. And again, it is for getgutanswers.com. You can also visit triosmartbreath.com or ibs-smart.com. That'll bring you to the same places. But getgutanswers.com. And when you go into your checkout, you can put in GetGut50 and you will receive $50 off your order. All right, so I think that's all I wanted to mention, just in case you had some questions about the test that I saw coming in. But I will send it back over to you, Dr. Pimentel, when you're ready.
Okay, thank you. I'm back. There was one question that was sent in advance, and I wanted to bring it up because it's kind of like an unfortunate thing. Janice sent this in. She said, my doctor will not order the test. And it sounds like we won't order either test, which... And says that it's research test only. That to me is like beyond shocking, considering the fact that breath testing for SIBO has been around since 1980s. So 50 years. This person this doctor hasn't read a book. That to me is shocking. So I'm sorry, Janice, you're going through this. I hope you can find a way to get the test if you feel that you need it, or find a doctor who is a little more up to date. So that isn't even an answer because of 50 years of research. Not just me, even before me, the test has been available. It's just more modernized and better, but it's been around a long time. All right, Paige, I think you still had some more questions.
Yes, I have one here from Manuela. How to treat IMO while pregnant and breastfeeding? Is ginger strong enough as a prokinetic?
So I have many patients, obviously women, IBS is more common in women, and EMO is quite common in female patients of younger age groups, and then they do get pregnant or start to have a family. And generally what we recommend, well, let me say a couple of things. I don't want to get too far into treatment before I talk about this. For some reason, when women are pregnant, a lot of things improve. So in Crohn's disease, just to digress even further, in Crohn's disease, there's a 1/3, 1/3, 1/3 rule. 1/3 get better, 1/3 stay the same, 1/3 get worse. In SIBO, IBS, we see about 70% get better when they're pregnant and 30% stay the same. Almost never do we see people getting worse during pregnancy, which is great. And we see that women who are pregnant, their autoimmunity is less, and it's very strange. So we haven't actually measured vinculin antibodies during pregnancy from before pregnancy to see if they go down. That would be a very interesting study to do, and I just thought of it as we're talking here. So this is a very good question for me to answer sometime in the future. But people get better. But what we do is we try to manage the bowel habit during pregnancy, because you can't take rifaximin. You cannot take rifaximin during pregnancy. It is not a good drug for pregnancy. And a lot of these drugs are not good for pregnancy. And you can't do an elemental diet during pregnancy as well. It just wouldn't be wise. So we generally manage symptoms. For example, magnesium is very safe in pregnancy. And so magnesium as a treatment for constipation is a common one that's used. And there are other therapies as well. Ginger probably won't work very well, but it's worth a trial.
Thank you for that. Dina's asking, do you ever titrate motility with the severity of anti-vinculin levels?
So we titrate the motegrity to make sure a person has a beautiful bowel movement once a day, first thing in the morning, and we will do that. And if that's not happening, and usually it's because the antibodies are high, and when the antibodies are high, there's more bloating still because the wiring's not working. So we will titrate that. So we will go up to 2 milligrams, even 4 milligrams in some rare instances where the antibodies are very high. But I can't say, oh, if the person's over 3 for their antibody, all of those patients get 4 milligrams, or all of the ones from 2 to 2.5 get 2 milligrams. It's a little depends on the person. But generally speaking, yes, the higher the antibody, the sicker the patient is, the more challenging they are.
Thank you. Karen is asking, what if you are lactose intolerant? Can you use the glucose test?
So glucose is a simple sugar. It's a monosaccharide. Lactose is a disaccharide. And you don't have, if you're lactose intolerant, you don't have the enzyme to break the disaccharide, but glucose is perfect. If you can't digest glucose, you wouldn't be here, because glucose is the only molecule that's your energy molecule from carbohydrates. Everything breaks down to glucose. So you can't be allergic to glucose. You can't be intolerant to glucose. That's just not a thing.
Okay, we have another question coming in. I'm hoping to find out when to take NAC with rifaximin, same time or before, after you take rifaximin pill.
Yeah, so the new formulation of NAC is a special delivery system that's going to be in the trials for the new product. People try to take NAC with rifaximin to treat SIBO and ISO now. What we find is that there's so much mucus in the stomach, most of the NAC is used up in the stomach and never gets to the small bowel. But if you want to try it, I usually give it together with the rifaximin, not separately. And sometimes it works, sometimes it doesn't, but it's going to be better when it's all together in the capsule.
That makes sense. Okay. All right. Omar is asking, SIBO hydrogen. Why do I have such excessive burping, especially when I don't eat? Is there any relief?
Yeah, so the gas is being produced everywhere, and principally we see, when we do the Reimagine study samples and we collect juice from the small bowels, from the duodenum, and we see such high amounts of E. coli and Klebsiella right there in that duodenum. That gas is coming up as well. And so we also see an association between hydrogen sulfide and reflux. It's a new association. We presented this at DDW. I'm not going to get into too much details because it's kind of exciting, but I can't talk about part of it because we haven't published it all yet. But hydrogen sulfide can lower the valve between the esophagus and stomach pressure, and that can also make belching more. So if some people with hydrogen sulfide could actually have more reflux, more belching, because of the way it's changing the muscular function of the valves.
Okay, great. Thank you. Devin is asking, I took Xifaxan and neomycin after the breath test. I had severe diarrhea even while taking these antibiotics. Any thoughts as to why?
So Devin, so did Devin have methane? I don't know. Did you say that?
It just says I took Xifaxan and neomycin after the breath
Yeah.
test.
So we have noted that in a group of men who take rifaximin and neomycin, if they don't have methane or their methane is quite low-ish, that they can end up having more diarrhea on the rifaximin and neomycin. So I would only give rifaximin and neomycin in a patient who has methane and is simultaneously constipated. So I would not do it if they're having on the loose side or diarrhea or mixed, because of that issue. That sometimes happens. So I hope that helps Devin, but I don't have any further information from Devin.
Thank you. Do you have time for one or two more?
Yeah, one or two more sounds good.
Great. I have Shima here, and she says, I had an appendectomy and got diagnosed with Hashi at the same time. Can you talk about the adhesion in relation to SIBO? Thank you.
So Hashimoto's, is that what?
I believe so, yes.
Okay, Hashimoto's. So interestingly, we just published a paper, it just got accepted, and it was presented as an oral at Endocrine Society, that Hashimoto's thyroiditis, that autoimmune thyroiditis is associated with IBS and SIBO. So that paper will be out in literally maybe 2 weeks, but we already presented it, so it's public information. I can say it online. So if you had appendicitis and you took the appendix out, you might want to be careful that you don't have adhesions that could be causing SIBO also. I think that's the gist of the question. But you have to do a barium to look for adhesions from appendicitis.
Okay, thank you. And then we have Celine asking if you've done the elemental diet for 2 weeks for IMO and then reintroduced food and had a resurgence of symptoms, would you recommend doing the elemental diet again?
So we have patients who've done it more than once or a little bit longer than 2 weeks. So in the original elemental diet trial, which I did in 2003 when I was a child, the elemental diet we did in the pre-trial stage, we did 7, 10, and 14 days and 21 days. And 7 didn't work, 10 was better, 14 was good. We got about 70% eradication. And 21 days was 5% better than 14 days. But asking a person to do an extra week of elemental diet to get that extra 5% is a little tough for most people because that's 3 full weeks of elemental. So there are patients who can benefit from a third week. And so I don't know whether that's the situation for this person, but that is something that we do. What I worry about is doing it over and over again because it is expensive, and I don't want the folks on the line here to think that they should do elemental over and over again because it's $750 each time for 2 weeks. Now you don't buy groceries, but because you're just eating this, but still it's expensive.
I do have one last question, if you don't mind. It does kind of go together with the diet conversation.
Okay.
But Steve has said, I'm starting to lose hope, so I have to keep trying new things over and over again. I have heard that the carnivore diet can heal SIBO. Is this true? Can you help me?
Okay. So first of all, never lose hope because we're working day and night, and I'm trying to give, I try in my presentation to give you a high degree of optimism because we have new therapies coming and they are so much better than what we've ever had before. And it's just going to take time, and I wish it could happen faster. I wish we could just start putting it in capsules and giving it to people now, but it has to be done properly, has to be FDA regulated. You have to do the proper studies for safety, and has to be that way. But, a carnivore diet, a high protein diet, low carb diet does help overgrowth because the bacteria in the gut, it's sort of like this. If you have your olive oil, you don't put it in the fridge, you leave it on the counter. Bugs don't grow in olive oil. They just don't grow in oil. If you put 2 tablespoons of sugar in that olive oil, it won't last a week. They want sugar, they want sugar, they want sugar. The problem with a pure carnivore diet or a paleo diet or a pure protein diet is that it doesn't always contain all the nutrients that you need. So there are some disadvantages to that. But the less carbs you have, especially fiber, you can make the overgrowth symptoms less, but it doesn't solve the entire problem. And it's not going to work as good as getting rid of the overgrowth with antibiotics in general. So I have not seen routinely patients getting more than 40% just with diet alone better, where I can see 80, 90% improvements when rifaximin works, for example. So yes, you can do it, but just understand that it may not be perfect.
Thank you very much, and really appreciate you taking the time to answer these questions and kind of get into the things that we want to know that hard to find information on. So really appreciate you being with us tonight, and thank you to everybody for joining us tonight. I hope and we hope that you found this webinar informative and empowering. Is really what we want you to feel, that we can get through this all together and sharing this information. If you have any questions or you want to find out some more information, please visit our websites, triosmartbreath.com, ibs-smart.com, or getgutanswers.com. And don't forget, if you do order any of your tests online, to use the GetGut50 coupon code for $50 off when you order any of the tests online. Thank you again for spending a few extra minutes with us, Dr. Pimentel, and everybody have a wonderful night.
Thank you, everybody. Thank you.